Today we will be presenting our Tanner's Clinical Judgment Model project. In my group is Aiden and Sam, and my name is Priyanka. Today we'll be presenting the case of Lucy Bell, a 77-year-old female who was admitted to the emergency department with acute exacerbation of heart failure. Lucy was discharged just 10 days ago, but returned due to worsening shortness of breath, rapid weight gain, and significant bilateral leg swelling. She reports following her fluid and sodium restrictions, yet continues to gain 1 to 2 pounds per day, and now presents with +2 pitting edema to the thighs, crackles bilaterally, and oxygen saturation of 87%. Lucy's medical history includes hypertension, type 2 diabetes, atrial fibrillation, heart failure, and hyperlipidemia with a BMI of 32. Her current medications are warfarin, Ramapil, candesartan, metoprolol, furosemide, atorvastatin, empagliflozin, potassium chloride, and despite taking oral furosemide as prescribed, her urine output remains low at 15 milliliters per hour, indicating that the medication is no longer effectively managing her fluid overload. So, to guide our clinical reasoning and prioritize nursing care, Tanner's clinical judgment model will be applied to Lucy's situation. This framework supports systematic assessment, interpretation, and action in complex cases like her. Based on her presentation and lab findings, the priority problem identified is fluid retention. Addressing this issue is critical to improving Lucy's breathing, reducing her edema, and supporting kidney function, and preventing further cardiac strain through timely interventions and interprofessional collaboration.
We will now look at the noticing, the subjectively and objectively relevant clinical information for the case study. When we took a look at the clinical data, we noticed that her vital signs are the most important here. We see her blood pressure is at 164/91, which is high. Her heart rate is also high at 118 beats per minute, and we note that is irregular, often displaying arrhythmias. Her temperature is a normal value of 36.7 degrees, and her respiratory rate was also high at 28 resps per minute, which could indicate some impairment with the lungs paired with her SpO2, which is low at 87% on room air. If we look at her lab values, we notice that the injection fraction is low at 51%, indicating some issues with her heart. Her glucose levels are high, as were her HbA1cs at 11 millimoles per liter and 8.9% respectively. These could indicate issues like diabetes. Her BNP, which is a direct indicator of heart value, was 630 picograms per milliliter, when it should have been less than 100 picograms per milliliter. This is, again, a strong indicator of heart failure and could be a contributor to why she has such swollen legs and shortness of breath. Her GFR was 43, which is low considering it should have been between 90 and 120 milliliters per minute. Her creatinine levels were high at 150 when they should have been between 45 to 110 micromoles per liter. This indicates some renal impairment, which could be a factor of her heart failure. Her INR is at 2.5, and we'll look at this value again later when we discuss her medications. Her potassium levels are sitting on the low end of normal at 3.5. Her sodium levels are also sitting at the low end of normal at 135. Her hemoglobin levels were low for a female, just under the threshold of 115 to 160 grams per liter. Her hematocrit level was also just below the normal 0.36 to 0.46. Hers was at 0.34. If we take a look at the clinical presentation of our client, we notice that she's a 77-year-old female, and her primary diagnosis was heart failure. The patient cannot catch their breath and has shortness of breath on exertion. There's also +2 pitting edema bilaterally to the legs and crackles bilaterally. The previous 3 clinical presentations are direct indicators of the heart failure. There's probably some fluid buildup in her lungs, impairing gas exchange. The patient's also disoriented to time and place and only opens eyes to touch. They are unable to speak full sentences because of the shortness of breath. The patient is able to follow commands, has nocturia, and a low urine output of less than 15 milliliters per hour. If we take a look at some more of the patient data, we notice that she lives with her spouse, is independent in her activities of daily living, but has limited activity due to the fatigue. She's also a former smoker and has an estimated smoking history of 20 pack years. In terms of family history, her father died of myocardial infarction at 68 years of age. The mother was diagnosed with type 2 diabetes mellitus. In terms of her own medical history, we noticed that she was diagnosed with hypertension, type 2 diabetes, atrial fibrillation, heart failure, hyperlipidemia, and a body mass index of 32. Her current medications include warfarin, which is probably why her INR value is high to receive that therapeutic dose. They also take ramipril, which is an ACE inhibitor, candesartan, which is an ARB, furosemide, which is a loop diuretic, atorvastatin, often for hyperlipidemia, empagliflozin, which is for her diabetes, metoprolol, which again is a beta blocker for her heart, and potassium chloride. All these medications work to initially treat her heart failure, type 2 diabetes, and hypertension, as well as the atrial fibrillation with the potassium. All of these comorbidities might be displaying as more significant than they initially were, and their dosages may need to be titrated or changed to see better outcomes.
Now we interpret the data that we have noticed. We will look at the different data, both subjective and objective, that will impact her care, such as age and demographics, familial history, labs and diagnostics, and medication regimen. Lucy, a 77-year-old female, presents with shortness of breath, fatigue, and increased swelling. Our priority problem for Lucy is fluid retention related to heart failure, as shown by her elevated BNP, shortness of breath on exertion, bilateral crackles, fatigue, increased rest rate, low SpO2, low urine output, and increased lower leg edema. Our secondary problem statement was that she has impaired ventilation related to heart failure, as evidenced by pulmonary fluid backup, orthopnea, hypoxia, anemia, and confusion. Lucy's age plays a major role. At 77, she has decreased vessel compliance, reduced renal function, making her more prone to diastolic heart failure. Her BMI is 32, so obesity adds to cardiac workload and hypertension risk. She's a former smoker, and long-term endothelial damage from smoking accelerates atherosclerosis and decreases cardiac perfusion. Her familial history compounds this, as her father's myocardial infarction at 68 points to a genetic link for coronary artery disease, while her mother's diabetes and Lucy's A1C of 8.9% show a familial pattern of insulin resistance. Chronic hyperglycemia damages vessels, thickens the myocardium, and worsens diastolic dysfunction. It also contributes to renal disease, explaining her decreased GFR and elevated creatinine. Looking at her labs, her BNP is elevated, thus confirming heart failure, and preserved ejection fraction confirms that it's diastolic heart failure. Elevated BNP means ventricular strain and pressure overload, causing fluid backup into the lungs. This explains her symptoms: needing multiple pillows to sleep, not able to catch her breath, low oxygen saturation, bilateral crackles, fatigue, and low urine output. Anemia. With her hemoglobin of 112, this reduces oxygen delivery, forcing the heart to work harder and worsening symptoms. Her INR is 2.5, which is therapeutic for warfarin and is used in atrial fibrillation to prevent clots forming with the pooling of blood in the heart. Glucose and A1C remain high, confirming that the diabetes is poorly controlled, which stiffens the myocardium and impairs renal perfusion. Her GFR of 43 and creatinine of 150 confirm chronic kidney disease, leading to sodium and water retention through the RAS pathway, worsening edema and increasing fluid overload. If pulmonary congestion continues, right-sided heart failure could develop, causing pitting edema, weight gain, fatigue, and low urine output. Her medications support multiple symptoms. Furosemide, a loop diuretic, which may need a dose adjustment given the ongoing fluid overload. Ramipril and candesartan, as an ACE inhibitor and an ARB, inhibit the RAS pathway to reduce blood pressure and fluid retention. Metoprolol works to control heart rate, in AFib and decreases cardiac workload. Empagliflozin lowers blood glucose and provides mild diuresis. Warfarin, which is a main thing for atrial fibrillation, prevents pooling and clot formation. Atorvastatin lowers cholesterol and lipids, addressing atherosclerosis, and potassium chloride prevents hypokalemia from diuretic use. Overall, Lucy's presentation reflects diastolic heart failure with preserved ejection fraction, complicated by fluid volume overload, uncontrolled diabetes, and chronic kidney disease. The focus of care should be optimizing fluid removal, improving glycemic control, and supporting oxygenation to prevent progression to right-sided heart failure.
Number 3, responding, putting the care plan into action. Nursing intervention and rationale. A key nursing intervention is for the nurse to advocate for adjustments to Lucy's diuretic therapy. Lucy's symptoms indicate that her heart function is worsening, suggesting that her current oral furosemide dose may be insufficient. This is supported by clinical findings of rapid weight gain, +2 pitting edema to the thighs, shortness of breath, bilateral crackles, and an increased respiratory rate. The pathophysiology behind the intervention includes that IV furosemide is a loop diuretic that acts on the ascending loop of Henle in the kidneys. It works by blocking the reabsorption of sodium, chloride, and water, which will increase urine output and reduce excess fluid much faster than oral furosemide will. So the result of this medication adjustment is that switching to IV administration ensures faster onset and higher bioavailability, allowing for more of an effective fluid removal and quicker symptom relief. So Lucy will likely notice that fluid is leaving her body faster, which leads to increased urine output, reduced edema, her breathing is improved, her oxygen levels are improved, so decreased shortness of breath, cardiac workload decreases, which helps stabilize her condition. A physician can help by providing the order for the new medication. A pharmacist can review that order and ensure that the dose is correct for the IV form, and they can verify any potential drug interactions. A lab technologist will collect and then they'll analyze those blood samples and they'll communicate any findings to the nurse or the physician so that medication adjustments can be made. Some non-pharmacological nursing interventions include monitoring ins and outs. So this will just track all fluid intake and urine output to detect retention. So ins is everything that goes into the body and outs is everything that comes out. And in theory, we want it to be balanced. And a lab tech can help analyzing electrolyte levels in the urine to make sure that they are okay. Also, daily weight checking. Weighing daily will let us know how much weight Lucy is retaining in her body. And any weight gain over 2 pounds per day needs to be addressed, and the dose may need to be changed, and a dietitian can help to plan for a low sodium meal. Number 4, reflecting and evaluation. Evaluate intervention effectiveness. So rapid diuresis will have improved Lucy's urine output, breathing and oxygenation circulation is improved, lowered fluid retention in the lungs and the legs, decreased respiratory rate, heart rate, and blood pressure, less fatigue and nocturia. She may be oriented ×4 and able to speak without having much shortness of breath, and her creatine, GFR, and BNP levels may improve, and therefore IV furosemide intervention is clearly effective for Lucy. Follow-up care. When symptoms improve and fluid status is stable, Lucy can gradually transition from IV furosemide back to oral, but regular checkups will be needed for kidney function blood work, pulmonary edema, edema in the legs, weight gain, vital sounds, and lung sounds. Patient education on daily weight monitoring, a low sodium, sugar, and fluid diet, medication management, and recognizing early signs of her symptoms, as well as physical activity that she can tolerate and getting support from her spouse. These are all important for her to remain in good health. Barriers include cognitively, she may be confused, fatigue, shortness of breath, anxiety about her condition. Physically, she's advanced in age and has multiple comorbidities, low stamina. Socially, she may be dependent on her spouse and family with limited support and financial strain. And her complex medication regimen and delayed follow-ups are all barriers. Reflection on Lucy's health management. Our group recognized that managing Lucy's health requires collaboration across disciplines, including nursing, pharmacy, laboratory, and nutrition services to ensure the best approach. Through discussion, we emphasize the importance of early recognition of worsening symptoms and timely intervention to prevent readmission. This case deepened our understanding of how evidence-based nursing interventions, such as evaluating urine output trends, assessing lab values, and promoting patient education, can meaningfully improve quality of life and cardiac stability for older adults with heart failure. Reflection on Tanner's CJM. Tanner's CJM guided our decision-making throughout this scenario. The noticing phase helped identify subtle signs of fluid overload, weight gain, and edema, and low urine output, while interpreting linked these findings to heart failure decompensation. During responding, we implemented timely diuretic and monitoring interventions, and reflecting allowed us to evaluate Lucy's outcomes and our reasoning. This model reinforced the value of critical thinking and reflection in action, promoting safe, patient-centered care for Lucy. For the summary of Lucy Bell's case, our clinical reasoning identified fluid retention related to heart failure as a priority problem. The main intervention, switching her oral furosemide to IV administration, was chosen to achieve faster onset, higher bioavailability, and more effective diuresis. As a result, Lucy is expected to experience increased urine output, reduced edema, improved breathing, and greater comfort, helping stabilize her overall condition. Ongoing monitoring of urine output, potassium, kidney function, and blood pressure will ensure the intervention remains effective and safe. Reflecting on this case reinforced the importance of interprofessional collaboration, patient education, and empathy in promoting recovery and preventing readmission. Using Tanner's clinical judgment model guided our ability to connect assessment findings with timely interventions, ensuring our decisions were both evidence-based and patient-centered. Thank you.